It's it's great to have all of you both participating, and a special thank you to our panelists. We will go ahead and get started. I know that we're probably going to see participants logging in throughout the meeting, but because we have limited time, we want to get the program moving so that we have plenty of time, not only for the discussion between the panelists, but also to go through any questions and information that you may want to hear or discuss as well. So, as Kelsey just mentioned, we do have the Q&A opened. We will be looking at the questions so that we can ask those questions to panelists or answer them in the chat, depending on the type of question. But feel free to use the Q&A so that we can start getting information back and forth between the panelists and back to you. So thank you for that, Kelsey, for making sure that we have that ready to go. So we've just put up the agenda, and this is to get us through some of the key topics. We may not strictly adhere to the agenda, but just this gives us a bit of structure so that we can organize our thinking as we have discussions with our panelists. So we're going to start with the welcome and introduction. Then we're going to go into an overview of state activities. There's been a lot of state activity on PDAB this legislative session. We've got some really excellent insights from our panelists that we'll be able to share. Then we'll have a kind of a group discussion on strategic outreach to patient communities. And this will be a discussion amongst the panelists and hopefully you in terms of use of the Q&A. We will have a very specific discussions on how to get people involved. And then at about 11:40, we will move on to becoming more proactive in 2025. And then we will wrap up around 11:55. So Kelsey, can we go to the next slide? am very happy to introduce our panelists today. We have Bridget Serrett. While she's working through that, I'll continue to introduce the panelists. Bridget has been very active on PDAB issues, and we're very excited to have her as a panelist today. Our second panelist is Patrick Plews, and he's the Vice President of State Government Affairs at BIO. And many of you have known Patrick for many years. He has worked in rare disease issues, and he is very, active and plugged in on the state level. And we are very pleased to have Patrick with us this morning. And Harry Giewaner, and I'm sure I butchered that, Harry, and I apologize. But I met Dr. Giewaner here in Virginia as we were lobbying and advocating on PDAB issues in Richmond. He's a pediatrician and pediatric rheumatologist, and he is someone who's been very active in PDABs and in patient access. And so we're very pleased to have Harry with us this morning as well. Next slide. And again, this is just an overview of some of the things that we want to accomplish or cover. There's a lot of information about PDABs out in the marketplace, and we want to make sure that we provide really good information here regarding not only PDABs, but some of the solutions, things that we should look at to enhance patient access and reduce patient out-of-pocket costs. And again, drive value for patients. And so that's really been our focus in the PDAB series. And we want to continue to be able to focus on that. Next slide, please. And this is just a general overview of PDAB. And we have talked about this in our previous PDAB workshops. This page will be in the slides that are circulated after. And it talks a little bit about some of the history around PDAB, the focus of many of the states in terms of how they have set up and structured their PDAB. And again, an interesting piece that is actually growing in terms of one of the options in creating a PDAB, which is a PDAC or advisory council. And that advisory council will sometimes bring in various stakeholders and give them a little bit more breadth in terms of trying to bring up issues, provide good advice to the PDAC or the PDAB. But often the PDABs will listen to the PDAC or they don't listen to the PDAC. So that's an interesting wrinkle that has occurred recently in some of the PDAB legislation to create a PDAC as a way to broaden it beyond just the insular appointees on the PDAB. Next slide, please. So I would like to actually work the next section about our state updates on PDAB activities. This will be both legislative and regulatory, and have a discussion with our panelists. Now, I have some very detailed background slides. There are two detailed background slides that will go out with the deck that has very specific information about each state. But what I'd like to do is use this as an opportunity to talk to our panelists about some of the current updates, some of the activities that are going on, things and insights that they're seeing in PDABs, and really give them an opportunity to share some of that information. So Kelsey, if you could go to the next slide. So having said that, the legislative sessions are still moving forward. There's a lot of, kind of moving pieces in terms of where PDABs are. For example, Oregon is on a regulatory path right now, whereas we still have some active legislation in a few of the states, et cetera. And so, PDAB is moving into a kind of pathway that's not only legislative, but now we have a lot of regulatory side events going on, including in Colorado. And so having said that, I would like to ask a couple questions of our panelists to kick off some of our discussion. And Bridget, I know that you're heavily involved in some of the efforts, both on the regulatory side and legislative side. Could you talk to us a little bit about the legislative efforts in Colorado, and also then a little bit of an update about what's going on the regulatory side in Colorado?
Absolutely. Right now we have Senate Bill 24-60 out, which is to protect rare diseases and orphan drugs from the PDAB process, simply because it's an experimental process and we don't really know what the outcomes are going to be, positive or negative. And so that right now is scheduled for Senate floor work on April the 1st. Unfortunately, this bill is really struggling to get through, and we definitely need more patients to be aware and more people writing in, calling in, letting our legislators know they need to pass this bill to protect orphan drugs for rare diseases, because we just don't want to experiment with people's lives. And that's what's going on the legislative side right now. Regulatory, NBRL has just been voted to have an upper payment limit. That process is going to start. It will probably take the next 6 months for them to thoroughly investigate and decide what the upper payment limit is, whether or not it's appropriate, and that sort of thing. And up next, Cosentyx and Stelara. And unfortunately, on the regulatory side, we haven't had much patient participation. Less than 1% of the patients on the particular drugs have participated in either of the surveys. And I think Stelara only had one patient participate. So we're really struggling trying to get some engagement going to make sure that the PDAB can make informed decisions.
That's very interesting, and it goes back to something we've been talking about, Bridget, quite some time, is that, you know, patient engagement. It really is important all throughout the process, not just in terms of lobbying and advocacy around the legislative effort or around one or two specific therapies, but there are a number of therapies now moving in Colorado, and that patient engagement is ongoing and needed on an ongoing basis. And it often crosses diseases and therapeutic areas. And some of the patients get involved, and others, it's a challenge to find those patients. And so that's an ongoing issue, I think, that we're going to find the more and more we get involved with PDAB. Patrick,
Absolutely.
I know that you know, you've got a very big picture view on PDAB, and so you're seeing a lot of these things moving all at once. Could you provide us with a little bit of insight in terms of, you know, some of the key priorities that Bio has had, areas where you think that there are opportunities for additional engagement?
Yeah, thanks, Mike. So yeah, I mean, look, there's actually, there's PDAB bills in some form of under consideration in 1, 2, 3, 4, 5, 6, 7, 8, 9, so 13, 14, 15, 16, 17, around 18 states right now. So it's kind of like a game of whack-a-mole for a lot of these. I will tell you, thankfully, that some of them are dead. There are bills in Arizona, Iowa, West Virginia, and thankfully in Maryland, there was a bill to expand the PDAB into other sort of commercial markets, which we think is dead for the year. So that's good. But we still have some states where we are very concerned with, in terms of bills that have legs and the potential to move. I think first and foremost is Connecticut. That state, just giving the environment for the industry in that state, is going to be a very difficult slog for us, where the patient voice is really going to carry a lot of sway as this bill makes its way through the committee process. It's Senate Bill 8, which seems to be the main bill that people are focused on right now, which is sort of an omnibus healthcare bill that includes some PDAB provisions in it. Illinois is another state that gives us a little bit of concern. As many of you know, there's a prescription drug affordability committee that's already set up in the Illinois House. Thankfully, that committee chair, from what we understand, is not very supportive of this idea. So the bill sponsor has aggressively tried to put this into another committee where it's in a health access it's a health committee, actually. I forget the long name of the committee, but that bill is under consideration there. I think again, Illinois provides a good opportunity for patients to go in and talk to legislators about the problems with these bills, because we do understand from some members of that committee that they're not sold on this idea yet. They want to learn a little bit more about PDAB, so that provides an opening for patients to go in and to talk about legislators on that committee, to talk to legislators in that committee about some of the access challenges that could come about if this legislation were to move forward. Obviously, Michigan, we have a bill out there that's still pending in the legislature. It passed the Senate last year. It's in the House right now. The Michigan legislature has been preoccupied with redistricting and with primaries. I think in mid-April, when that settles down, they're going to come back and look at a whole slew of bills, and this could potentially be a piece of legislation that gets some attention. Again, efforts in Michigan are really to work in the House to convince legislators that now's not the time to push this type of legislation in Michigan. And then finally, obviously Virginia, we have the bill that passed the legislature. And I know that, Bio, Pharma, Virginia Bio, and a lot of patient organizations are aggressively working to push Governor Youngkin to veto the legislation. He has until 11:59 p.m. on April the 8th to make a decision on this. He's got several bills in front of him. And, you know, there's also a lot of talk in Virginia about building a sports complex in Northern Virginia, that all these bills start to become relevant to that issue because they turn into political pawns or trading opportunities for the governor and the legislature. So we're keeping a very good eye on that. We know that philosophically the governor's not supportive of government imposed price controls or the whole concept of a PDAB with the UPL authority. And obviously, you know, this bill was passed with a Democratic majority in the legislature. So I don't think he's going to be too keen on supporting anything that a Democrat legislature has put before him. That being said, there's a lot of political maneuvering going on in Virginia right now on other unrelated issues, and this could get swept up into that. So we're keeping a very good eye and keeping pressure on the governor to really push him as to why this is bad policy and why he needs to veto the legislation. And then finally, in Maine, we have a bill that's making its way through the legislature to provide the current PDAB with upper payment limit or UPL authority, and tying that authority to what's happening in Congress or what's happening on the federal side with the maximum fair price deliberations at CMS. So those are the states that we are really keeping a close eye on. And those are the states where we think, especially Connecticut, Illinois, and Michigan are states where we think that the patient voice is particularly critical and in the legislative process. And I think, you know, talking about, well, I would just say talking about the whole idea of access and the fact that the real problem with affordability is insurance design, and the challenges that these bills have on, especially for patients in areas where there's an unmet medical need, I think is really where your message resonates with policymakers. So just I appreciate people weighing in on the rare disease aspect of this. And, you know, we hope that you can still do it moving forward or continue to do it moving forward.
Terrific. Yeah. And Patrick, just be assured we will.
Good.
And, you know, it's really interesting in terms of some of the underlying messaging that's being used across the states in terms of support of PDAB. And that patient cost and patient out-of-pocket cost seems to get lost in the shuffle. And Harry, I know you've been involved a lot in Virginia, as we've talked about. You know, the proponents of the bill have even moved back from saying, "Oh yeah, this will save patients money," to actually being much more amorphous. Harry, would you share with us some of your experiences and key learnings from, you know, interactions both in Virginia and in the other states that you've been working on this year as well?
No, sure. You know, and I think, you know, Patrick teed this up very well. This has turned into really a political soundbite for everybody. And the folks who are, you know, supporting the PDAB legislation are just talking about it in global sense of course, drugs are going to be, we can make drugs more affordable, and therefore everybody should do this. And actually, there was an article that they, in their talking points that they've put out about, you know, that if the governor doesn't sign on this bill, then he is being a pawn of big pharma as another way of trying to do this. I think the biggest lesson I learned during our legislative session, and you know, for those of you who don't know Virginia, we had a long session this year. We have long and short sessions. The long session is 60 days. The short session is 45. So there really is very little time to see people while they're there. And the lesson to me was how much work had to be done in advance of the legislative session. And I think this will, you know, set things up for our further discussions. But it was clear to me that this was a done deal once we were in the legislature, that the points that we made about how really everybody talks about, oh my goodness, there's 11 states that have got PDABs. Well, no, there's 11 states that have PDAB legislation authorizing this, but there's only one state that's doing anything. And so the concept that this is a totally experiment that's being foisted on so many states and the patients therein is huge. I think one of the other points that, again, while we're talking about patients specifically here, one thing to realize from a physician standpoint is that for medications that are physician administered, there is no provision within these to make sure that the physician can economically provide these medications, because one, you may not be able to purchase the medicine at a price that allows you to to stay in business. And second, there's not necessarily any components in there to pay for your administrative costs or anything like that go along with the administration. And so when one looks at total cost, which is supposedly what the legislature is looking at, you're going to start seeing people having to go to hospitals or other more expensive venues to get their medications than with their own physician. And I think the other lesson that I've seen as we talk about language is the conflation of price and cost. People go back and forth about that. And really all the PDAB can do is a list price. It has little to no ability to do anything about the patient's actual cost. And that to me was the other lesson that, about how people don't understand this. And the sound bites are great. And just to add what Patrick is saying, there's a lot of conflict, I think is the best term, between the governor and the Democrats that hold both houses of the legislature over one of his pet projects. And I think the question about whether he signs or vetoes this bill is going to come down to what, if any, horse trading he can do to get his pet project through as well. He vetoed this bill last year, saying he didn't like price controls. And in fact, a number of professional societies said, well, we're not going to make this a priority because the governor's going to veto it, and so we shouldn't waste political capital on it. And unfortunately, no one could predict exactly how this ended up going. So I'll stop there so we can move on with other discussions.
No, I think that a couple of really important things have come out in this discussion, and that is clearly that there is a lack of understanding in terms of how the pharmaceutical marketplace interacts with patient access. And Bridget, Mary was talking a little bit about understanding the physician administered model. Can you share with us just your thoughts about, in terms of your interactions, the patient journey is really important as well to marry up with the work that a PDAB is doing. In terms of your perspective, in terms of your perspective, what do you think are some key things that policymakers really are missing out on from the rare disease community?
Oh, goodness. There's a lot that the policymakers are really missing out on. They don't necessarily understand the supply chain or the impacts that an upper price limit will have, because realistically, it's just an insurance reimbursement cap. And so the PDABs actually were very concerned that they could cause even more health equity disparity. They could raise the cost to patients simply because it's going to take money from patient assistance programs that patients heavily rely on in order to access these medications. And then there's also the issue of whether or not you can enforce an upper payment limit on federally funded insurance like Medicare and TRICARE. Right now, there's a big question mark whether or not those will even be impacted, because it's federal and you can't really enforce an upper payment limit. So I think the dynamics of how a rare patient or just a patient in general accesses a lot of these injectable and infusion medications is just lost on legislators. They don't understand there's prior authorizations, they don't understand the copay structures, and they definitely don't understand how, even though you can have a list price of something, and even though the insurance reports that a patient's copay may be $2,000, they don't necessarily understand there's patient assistance programs for most of it. And if they stop reimbursing the pharmacy for what it costs to get the medication, it's just going to cause a lot of logjam in that supply chain.
Yeah, they really don't understand about the legal kickback system that's involved between the list price and the cost or the net price. And you know, again, to me, this has all come down to sound bites. And you know, it's hard to explain the complexity. We had a governor a number of years ago who ran on ending our car tax, and the unintended but predictable consequence was that they had to make up all the money they were making on that tax somewhere else, and people were not happy about how it was made up, but it sounded great and won the election. I think this is a similar situation.
Well, thank you for sharing that, because you know, from based on my experience of meeting with legislators as well, is that, you know, they almost look at their state marketplace as if it's in isolation from other states as well, and don't realize that there is a very robust interstate commerce system that you know, drugs and therapies are sourced beyond the borders of their states, where the PDAB won't have control over the price of those products. And so, as I talked with many pharmacists, legislators actually, they understood, and because they are the ones who basically hold the risk, Harry, as you just pointed out. You know, as those chargebacks and things work through the system, and the pharmacy then gets its final payment. And you know, from products that are sourced outside the states with no UPL, you put the pharmacist at risk, or the specialty pharmacy in state, or again, because rare disease, sometimes hospitals are central to a rare disease patient care. So it could be a center of excellence. It could be, you know, a pediatric hospital. It could be, you know, any number of venues that would have to hold the risk of those products, not knowing what price they will actually get paid for them. So, you know, and to answer one of the questions, if we could put together a single slide with the legislation and regulatory things that are going on, yes, we will amend some of the slides that you're seeing here and provide those for you in a much more comprehensive way after the meeting. Next slide, Kelsey. So I did just break Oregon out because they are moving into a regulatory process in Oregon, or I'm sorry, a legislative and regulatory process in Oregon. And I think it's important for us to also keep our eye on. Next slide, please. And in Oregon, the PDAB has launched a listening round where they are reaching out to patients. And if you go to the Oregon website, there is a sign up page. And they are basically, as Harry described, happened in Virginia and in some other states. They're looking for what appears to me to be the horror stories versus the positive experiences that patients have with, financial assistance, copay foundations, et cetera. And so, it's one of those areas where I think when we talk about patient engagement needing to be all the way from conception, all the way through the passage of the legislation, we need patients involved. And then during implementation, it's critical that patients get involved, as Bridget described, on some of the questions we go to the previous one, please. On some of the questions that are asked in surveys and things where they're not getting patient participation. And so the PDAB's not getting a balanced view of how the rare disease patients, specialty care patients, oncology patients, et cetera, may find that they have access issues based on a PDAB decision. This is an active opportunity for us to get more involved and to get patients very, very involved in that listening process that Bridget described as so important to what's going on in Colorado and very, very important, again, in Oregon. Patrick or Harry or Bridget, any comment on Oregon before we move on?
No, I think, one of the points about getting horror stories, again, goes back to the lack of understanding of the whole drug pricing and supply chain. Because there was a recent press conference that sponsored Virginia Bill had in some town, and had a patient talk about how she has Crohn's disease, and and her drug costs $26,000. She's not paying $26,000, but all the patients can see, and the only thing that is public is the list price. And nobody knows what the net price or the actual cost is or what they're paying. They do know they're paying 20% of $26,000 or whatever for their co-insurance. But again, this comes back, as Patrick said, this is about formulary construction. All of this pricing is about formulary construction, and you can't have access to a drug unless it's affordable and available. And if it's not on the formulary, it's not going to be available no matter how affordable it is. And I think that's a message that we've got to be able to educate everybody about.
I think specific with Oregon too, the reason they're having these listening sessions is because patients got involved and started yelling and they got loud. But we also have to remember too that with Oregon specifically, the process to attend these listening sessions and provide comment, I think you have to sign up 3 days in advance, and they have a number of hoops that you have to jump through. So it's important to pay attention, not just on the day and expect to be able to submit comment. You actually have to pay attention to how that state, like specifically Oregon with the 3-day sign up, they run their program so that you can definitely be effective in how you participate.
Thank you, Bridget, for that insight. And that's very, very important to understand is there are different rules in each of the states as well. And so understanding those rules before you participate will help you optimize your time that you have so that you can focus on either the key messages or get the right patients to that forum or venue. But please be aware that there are a lot of process issues that we need to understand as you sign up and go into the process. I do believe that it's very, very important to have a patient perspective that understands the access issues. And go back to what Harry and Patrick said earlier. I was at a couple of hearings, and I recall, the supporters for PDAB bringing up a patient or two that had Medicare Part D coverage issues. And they were very eloquent in their testimony, talking about their disease, talking about the unaffordability, and then really it focused on it was unaffordable because they were in Medicare Part D, And we all know that that was a benefit sign.
Yeah.
It wasn't the cost of the product, it was the benefit. And that's since been fixed. But again, it's conflating the two issues, which are, the price of the drug and the cost to the patient. And that's some of the confusion we're going to continue to encounter, I believe, as we engage, for example, in Oregon and other states in terms of implementation.
And I would just say in Oregon, I mean, right now they don't have upper payment limit authority. That's not in the legislation, but what they're trying to do is see the environment so they can push bills next year to grant that authority to the PDAB. So these listening sessions are one of the reasons they're trying to build up a case to implement a UPL. The other thing I'll say about Oregon, which I found disturbing when they did their first sort of pass through on reviewing therapies that could potentially be under review by the PDAB, was they picked out vaccines. And vaccines are and have been always the most cost-effective medication, public health tool out there. And it even ran counter to positions that the Oregon health authorities have even said in the past, where they want full access to vaccines. And thankfully, they withdrew that vaccine from consideration. But this just goes to show you that they are just looking at a list price of a therapy, and they're not taking into account anything else but that price. They're not taking into account the value of that therapy, the patient's impact of that therapy, or the impact it would have on broader public health if if access to that therapy became unavailable. So that's the flaw. Again, another flaw with these systems.
I'm going to agreed. And we do have a question. And I think it's timely to ask the question here. And this is from Michelle Rice. Do you think it's important that patients have better understanding of their actual cost versus what is paid by their plan? What do you think advocacy organizations can do to help patients better understand the difference and how to speak to it? Bridget,
Well,
I know you've, or Patrick, or Harry.
I was going to say, the problem is that everybody's gotten very good at disguising how much you're paying, and I think that transparency would help, but it, you look at your EOB the next month about how much you paid and how much your insurance company paid. But it really comes down, and for people with chronic and rare diseases, you've got multiple medicines and you've got multiple payments for all sorts of things. And so it's hard to identify the specifics. And the only number that is available is the list price. And so that's what everybody focuses on, because the PBMs and other folks aren't telling you how much the real price is.
Absolutely. I think it's
Yeah, and
also important for advocacy groups to start educating their patients and their constituency on how these things work, so that patients can be empowered to get involved and to speak to what's actually happening versus what people think is happening. So I think that's a very important thing to do.
So I think educating, finding a forum, and I don't know if it's RAAP or other patient organizations, where they provide a forum where someone can talk about making patients more insurance literate, understanding what copays are, understanding what list price is versus what your insurance company gets the product for. I think that would also be a very important way to help patients better understand, to Harry's point, the difference between price and cost, because that is a difference.
agreed. And just to read Michelle's comments, because I think she's summating this really well, my thought is that this why we need to have patients stick to what their journey is and the cost associated with that, so that their credibility isn't called into question when they say this drug costs me 100,000 a year. And I think that's really, really important, is that the patient journey and how they're accessing care and treatment and what those cost to them, when they then stand up and testify and someone says, oh, this costs over $100,000 a year for patients, that they have a really good handle on those costs and can articulate those, because that's really the way to counter that. Because as we discussed before, you have organizations like AARP, you have various potentially unions and others saying, oh no, oh no, no, it costs the patient this, and that's not the reality. So we have a lot of people speaking for patients, and the patients need to be both more articulate about their actual costs and then showing up. And that's, I think those are the two aspects that we keep coming back to, is understanding my own costs and then being able to articulate those on an ongoing basis or when it's appropriate.
Now, I think one of the other opportunities, because, quite frankly, physicians don't understand this either unless they're doing infusions and have to calculate things out that way. But I think a real opportunity for patients is to educate their physicians and provide their physicians with information to share with other patients about what's actually going on and the labyrinth that everybody goes through. Because, docs get accused of choosing medicines that are going to make them the most amount of money, and that's not how it works. We say, well, we think this is with the patient, say, this is the best medicine. Now let me look at your insurance formulary and see what's available. And I think, again, presenting this in the context of what's going to be available on your formulary and how that is based on the list price, but it's not based on what you pay. There's examples of some rheumatology drugs that one, same class, one's 70,000 a year, one's 80,000 a year, and one's 30,000 a year. Guess which one is not on the formulary? It's the $30,000 one. And so that kind of complexity and business issue has got to be brought up as well as we move through all this. There's no incentive for the companies to lower their prices based on what pharmacy benefit managers want in order to be on a formulary.
Thank you for that, Harry. We're going to have to move to the next slides. So this was a terrific discussion, and thank you to our panelists. Let's go on to the next topic. There we go. We've just talked through a lot of this. I'll leave this slide in the deck for afterwards, but this is a summation of some of the various areas that we've discussed, and some of the key things that I know I've observed, and they're very similar to some of the things that our panelists have shared. Could we go to the next slide, please? So that takes us to a really interesting area I want to discuss for just a few more minutes. In a lot of our PDAB work, we work across kind of disease states and areas. We work with patient organizations, professional organizations, and even our trade organizations on PDAB issues. And we've talked about the importance of engagement from the beginning all the way through implementation and on an ongoing basis. And yet sometimes we find gaps in terms of being able to find the right patients. And I know at RAAP, we've done a lot of work to build a patient access caucus where we bring together patients. We're providing educational information, materials to them. We are building out toolkits to help them be able to talk about cost versus price, about their patient journey, et cetera. And so the question becomes, on an ongoing basis, how do we grow those networks so that we have the patients prepared to tell those stories, because that becomes a challenge, and we hear it state after state after state. So I'm
I
just
can
turning that over to the panel. I know we have a lot of thoughts. Bridget, go ahead. Please kick us off.
In Colorado, one of the things that we have been doing is working with the Prescription Drug Affordability Board to partner with our larger health systems in order to reach the patients that this could affect. That's something that just in the last meeting, they've decided they want to do. We have several major large health systems here, like UC Health, Health First. Optum has a large patients provider service network. So we're trying to partner with the community and the medical providers and all of that to try to increase the understanding of what's going on and to reach patients. But it has been slow going. I think I've been mentioning that since August, and they've just now started to delve into why they don't have patient engagement and how they could maybe further that along.
Yeah, I think one of the things comes back to really you've got the patient, physician, pharmacist nexus that's at the core of all this. And I think we really need to start looking at how do we use the combinations of those three groups to spread the word and present it in a way that, you know, this is why it's important to you. It's not just everybody else. And starting to use pharmacies and physicians' offices as distribution points for information. And, you know, have things that can get done when you're seeing, you know, patient is in the office, you can get something signed and sent out while you're there, either before you're seen or after you're seen, so that we can really increase the noise about what a bad idea PDABs are.
Harry makes a really good point, and so does Bridget, that, you know, industry can only do so much. I mean, like I said earlier, I'm playing a game of whack-a-mole right there, and we are certainly going to fight these, you know, with every last breath that we can. But sometimes we are not the best messenger on certain things. And if you have physicians talking about the impact it's going to have on their practice and their ability to stock these therapies, and then how that has downstream effects with the patient that Bridget's talking about, that's the best messenger. And that's why, you know, we really appreciate any help we can get from other stakeholders who are really going to be impacted by this.
Yeah, and I absolutely agree. And you know, part of the challenge will be to continue to hold those kind of diverse patient communities together, and not like together from it and kind of the policy perspective, but together from the participation levels to make sure that we have the right patients at the right time for various aspects of PDAB, both legislating as well as PDAB decision making. And that's, you know, an area where I think that there can be continued cross collaboration. You know, again, we work across diseases and across patient groups, as well as professional and trade organizations, physicians, the life sciences, patient organizations. And the challenge is finding those right patients at the right time. And it gets into minutia the further you go downstream in PDAB decision making, where we're talking about maybe medications that patients haven't really been tuning into as being on the docket for the PDAB, and now we have to find those patients and let them know that these are challenges. So that I think is going to be an ongoing issue, and one that I think we can address together, but it's going to take a kind of a broader community to really focus the energy on that.
Part of the problem with any rare or chronic condition is nobody really cares about it until it affects them. And so
Correct.
you're always playing catch up on that. And so, I mean, that is an inherent difficulty. And part of it is how do we develop a message that says this will affect you or your family at some point in your life. and you want to be selfish and take care of them now before it happens. I think the other way for us to go after this is to go, to large companies and the HR people and say, who are your most expensive patients? And don't you want to do something about that? And the UPLs are not going to solve your problem. And how can we help companies help their employees and their employees' families by being involved with these things as well? I know that certainly in Virginia, the Chamber of Commerce spoke out against the PDAB. But I think that that's another opportunity for both recruitment to patient organizations by providing HR folks with ways that their employees can get support and help, and educate the HR folks about what the real costs are, not what they're getting sold by their brokers and the insurance companies.
Well, thank you for that discussion. And let's move on to the next slide. We just have a few minutes left, but I know at RAAP, we're already beginning to think about strategies moving into 2025. We've seen proponents of PDABs really working, as Patrick described, to expand the playing field in 2024. And we know that there will be a lot more legislative introductions in 2025. We have PDABs that will continue to move down the regulatory pathway. And so from a RAAP perspective, we've been looking at, spending a big chunk of 2024 becoming more prepared for 2025. And part of that we've already discussed, identifying patients, making sure that our patients have good information, that they are prepared to go into conversations with that good information and their patient story and their patient journey to be more proactive in 2025. But we also know that, as Harry pointed out, there's a lot more work that we could do. Bridget, as well, has talked about some of the areas that need improvement and work. And of course, Patrick talked about the importance of building those kind of networks and coalitions so that we're more prepared to be in front of these legislative efforts in 2025, rather than playing catch up and playing whack-a-mole. And so, for example, at RAAP, we are going to be moving into strategic mode, engaging stakeholders to develop messages, solution alternatives, focus on patient out-of-pockets in 2025, offer, amendments or substitutions to PDAB legislation that focuses more on the patient rather than on creating an experimental board. So those are some of the things that we're working through. I would love to get some of our panelists' thoughts on how to proceed and really how to look at 2025 as an opportunity. And feel free to jump in here, panelists, at this point.
I think 2025, there's a unique opportunity in 2025 that we're just going to be coming off an election year. So we're going to have a new slate of state policymakers and some governors. So it's a very good opportunity to get in early and meet with freshman policymakers to talk about these issues, so that you can make an impression on them before I would say the bad guys do. I think that's one opportunity in 2025.
I think one of the other things that I learned in terms of trying to get support in Virginia from national organizations that I'm connected with is that some of the national organizations don't have official policy yet about PDABs, that they have concerns and so on, but they've not come to a decision that they will officially oppose PDABs for whatever reason. So I think really one of our opportunities is to really go after the various national organizations and have them make this and also professional organizations. I can speak for the Medical Society of Virginia. We don't have a policy on this. And so we can't speak about it because we don't have a policy position. And so I think trying to get more national organizations officially stand up and say, we are opposed, is going to be very, very important as we go into 2025.
Absolutely. I would
Agreed.
agree with that. The other opportunity that we have is to connect with other states, because we know that lots of different states are going to be introducing this, and we can talk to them about our struggles, what's happening, and whatnot, in order to help get them versed in how they can talk with their legislators. So I think the connection in between the patients and the states, the organizations, national organizations, like Harry mentioned, all of that is going to be incredibly important to develop for 2025, so that we can make sure that these policies don't interrupt access.
Bridget, I think that that is such an important point, that I wanted to just kind of riff off of what you're saying. We have a lot of voices right now who are pointing to these other states as success stories. I've met with stakeholders and legislators in a number of states this legislative session, and they will point to Colorado as being successful. They will point to Maryland or Oregon or these other states as being successful, without hearing that no, really, actually, they're not that successful and have a lot of challenges, and those challenges have to do with patient access. They're not hearing that story. And so, Bridget, I think that that is really, really critical, that networking, because the legislators are looking for opportunities to help patients. And I just want to stress that. I don't think all the stakeholders on the other side are going after, PDABs in order to harm patients and harm patient access. They really believe that these can be helpful. But in so doing, they're also buying into the sales pitch from those who support PDAB. And so our voices are going to be critical to helping them understand in that cross-state communication that, in fact, that these PDABs have challenges. And so thank you for bringing that up, Bridget. Patrick,
Mike,
did you?
if I can add one thing, Mike, I think, one of the technically true but not entirely accurate things that is getting put out there has been how successful these PDABs are. What they need to realize is there are no PDABs that are successful, because only Colorado has got a PDAB that's operational. There are a lot of bills that have passed, but nobody is put this in, and we don't know what the outcomes are. And if you start looking at the unintended but actually predictable consequences of PDABs, that it's going to take you 3 or 4 years at least before you find out that it failed. And how can you call something a success when it hasn't operationalized yet and you don't have any metrics for proving its success? And I think that that's an important message we need to put out there.
Any other thoughts? I did have a comment from Melissa, and just to share it with all of you. As many of you know, RAAP is a C4, and so Melissa Horn's comment kind of struck me directly, and it's something that we have been considering and will also likely pursue very directly. But here's Melissa's comment: for C4s and PACs that can do candidate education, have you thought about developing a kit of some sort to educate candidates on the issue, since it's a major election year? C3s are limited, of course, majorly with election outreach, but just thinking out loud for those of you that can. And of course, RAAP can. Also, RAAP is very involved with some of the national legislative stakeholders, as many of you know. We partner with NCSL, and we build PDAB education into our ongoing educational effort. Again, it's a counterbalance. The proponents of PDAB are very heavily involved there as well. And so we are looking at various vehicles to provide these kind of tools and information. And thank you, Melissa, for your comment, because that's certainly an aspect that we can do more on. Any other thoughts before we wrap it up here? Can we go to the next slide, Kelsey? So I want to thank our panelists for participating with us this morning. This has been a very robust discussion on both what the issue and challenges are, as well as some areas that we can move forward together to address the ongoing issue of PDABs. Again, as Patrick characterized early on in the presentation, PDAB has almost become like a whack-a-mole where you expend energy and resources to try and fight and educate in one state, and then it pops up in another state. And I do agree with both Harry and Bridget that we have a unique opportunity between now and January 2025, given that it is an election year and it is an opportunity for us to begin to think more strategically as both organizations and as a community. RAAP will be engaging in strategic discussions later in the spring, and then moving forward to try and get us out in front of this issue. And many of you will likely be invited to be involved, and we would look forward to your involvement as well. So please stay tuned for that. Again, thank you to our panelists. This has been a wonderful discussion. Kelsey, could you go to the next slide very quickly? RAAP is also in the middle of growing and developing our patient engagement caucus. And this caucus is really focused on access issues in the rare disease community. This is one of the key issues that we will be working on to develop not only the tools, but to work with patients, patient families, caregivers directly to help them understand how their patient journey intersects with this issue. And so our next patient access caucus meeting is on April 17th. If you would like more information about the patient caucus, we have some of our patient caucus leaders on this call today. But you can also reach out to Kelsey at RAAP, and she will quickly connect you with the patient caucus. This is a really important area and way for RAAP to help expand the information, understanding, and allow those patients to become more empowered at the state and local level to make many of the connections we talked about this morning between price and patient access and out-of-pocket costs. And so there's a lot of work going on with our patient engagement caucus, and we would love to invite you to be a part of that. And with that, thank you again. We will end this workshop, and we look forward to having all of you participate with us in April. We will be sending out the announcement for that workshop very soon. Thanks again.